Okay. Namaskar. I'm Dr. Jindal. How are all of you? Today I'm going to discuss managing hydrosalpinx before IVF. I had a very interesting case today in my OPD with bilateral hydrosalpinx. So I'll show you some very interesting images of that patient and we'll discuss how to manage IVF, hydrosalpinx before IVF. So we all know that hydrosalpinx means blockage of tubes at either the femoral end or the even the cornual end, leading to buildup of fluid, and this appears second slide. This appears as hydrosalpinx on ultrasound. And the main reason for hydrosalpinx is actually infections. In our belt of UP, genital cox is a very important reason for hydrosalpinx, but there could be other reasons as well. Almost 95% percentage of patients are because of tubal factor infertility, and hydrosalpinx is seen in almost 10 to 30% of such cases. So, as we discussed, it could be genital cox as one of the important reasons for hydrosalpinx. It could be some sexually transmitted diseases, pelvic inflammatory disease, previous surgery, like previous surgery on appendix or on any intestinal surgery. Abdominal cox is also important reason. Pelvic adhesions because of any severe abdominal infection, and even frozen pelvis, as well as endometriosis is also an important reason for hydrosalpinx. The patient might be absolutely asymptomatic. The patient who came to me in the OPD today actually said that she had no symptoms, in spite of the fact that she had very large hydrosalpinx. Or the patient could present with an ectopic pregnancy because these are infected tubes are the ones which attract the pregnancy in the tubes. You can see a beautiful laparoscopic image here of a patient who had hydrosalpinx. What are the diagnostic tools available to us? The main tool available to us is an HSG, a hysterosalpingography, which will tell you and show you very clearly whether it's unilateral hydrosalpinx or bilateral, and also to some degree whether it's the degree of hydrosalpinx can also be charged on HSG. Ultrasound will show you hydrosalpinx only if it is severe. And any hydrosalpinx which is visible on ultrasound actually needs to be tackled before IVF. You cannot leave it. Even an SSG, that is sonosalpingography, also can delineate the extent of and give you more details about hydrosalpinx. And patients who have visible hydrosalpinx, you can ask for an MRI to know exactly how, what the pelvic adhesions around the hydrosalpinx, the extent of the hydrosalpinx, whether it's unilateral or bilateral. Laparoscopy still remains the gold standard for both diagnosing as well as for treating hydrosalpinx, especially before IVF. This is a very important, academic review where they reviewed 5,592 women undergoing IVF. Out of these women, 1,004 had untreated hydrosalpinx, and 4,588 had another type of untreated tubal blockage. And between these two groups, there were 8,703 total embryo transfers. And what did they find in this? They found that women with untreated hydrosalpinx had a pregnancy rate of only 19.67% versus 31.2% for women with other type of blockages. So definitely the hydrosalpinx decreases the pregnancy rates prior to IVF. The implantation rates were also affected in these patients with untreated hydrosalpinx. The implantation rate of only 8.53% for women with untreated hydrosalpinx compared to almost double in patients who acted as control. The delivery rates for women with untreated hydrosalpinx were 13.4% versus 23.4% for women with other type of blockages. And women with untreated hydrosalpinx also had a higher incidence of early pregnancy loss. So this study, it's a very big study and it says very clearly that hydrosalpinx should be tackled before IVF, should either be clipped or we can do a salpingectomy. So let's discuss the treatment options available to us. So treatment options include laparoscopic salpingectomy. Like you can see in this video, this patient had gross left-sided hydrosalpinx, and you can see that we are doing a laparoscopic salpingectomy. The only thing one needs to ensure is that you should be as close to the tube as possible without decreasing the ovarian reserves. And so you can either use a bipolar, scissors, or you can use even harmonic. The other option, so here we have a huge hydrosalpinx which has been removed. What is the advantage of doing a laparoscopic salpingectomy? It makes your ovum pickup easier, the accessibility of the ovary becomes better, and inadvertently entering the hydrosalpinx while you're doing an ovum pickup is absolutely avoided, because this is one thing which you should really avoid during IVF. The other option is the delinking of hydrosalpinx, which can be done in patients where it's frozen pelvis, the tubes are not accessible, you can't even, the tube, the femoral end is all adherent to the posterior wall of the broad ligament, you can't access the tubes. That is where you do just a delinking of hydrosalpinx by using either bipolar or harmonic, and delinking it by doing condual ligation. Another very interesting is sclerotherapy, which is actually ultrasound guided. And what you do in ultrasound guided sclerotherapy is that you take out the fluid of the hydrosalpinx. Almost half of the fluid of the hydrosalpinx is taken, and the entire fluid is actually taken out, and almost half the amount of 98% ethanol is then injected into the tube and left for 15 minutes for sclerotherapy to work. The tube shrinks and the hydrosalpinx is taken care of. But the only problem is that these hydrosalpinx can recur. Another, according to ASRM August 2020 issue, the latest treatment is hysteroscopic insertion of Essure, which is a device, micro device, which is fitted at the convoluted end of the tubes. But this is not yet available, and hence it is for interest that I included it in the treatment options. Another thing is that if at all you find at the time of ovum pickup, you see in hydrosalpinx, you can do a vaginal aspiration at the time of OPU, at the time of ovum pickup, and you can discard the fluid. Just make sure that your oocytes are not contaminated with this fluid. So you should collect it in a different test tube and discard this fluid, because it is all inflammatory fluid. It's embryotoxic as well as oocyte toxic. After all this treatment, the only option left to us is IVF, doing IVF after we have prepared these patients. Now, this interesting case which I saw today. This is the ultrasound image of a patient who came to me with secondary infertility. She had a 9-year-old girl, after which she had an abortion around 6 years back, and now she had been trying for pregnancy. She came to another doctor, and on the basis of the hydrosalpinx that the doctor saw and her MON2 being positive, she was started on ATT. There was no tissue diagnosis made, but since she had such gross hydrosalpinx and her MON2 was highly positive, her ESR was raised, but her menstrual blood for TB-PCR was negative. This just goes to prove that actually menstrual blood for TB-PCR should not be done, because it can even miss tuberculosis in such a patient. As you can see, the images, the second image. This patient had gross bilateral hydrosalpinx which were visible on ultrasound. You can see the very big hydrosalpinx and you can see the ovary on the right hand corner. This next image, this is the other ovary, the right ovary, with lot of multicystic appearance and fluid. And you can even see in the next slide, you can even see the incomplete septa, which are traversing the hydrosalpinx, proving the diagnosis of gross hydrosalpinx. So a menstrual blood for TB PCR was not able to pick up tuberculosis, even in a patient as gross with active tuberculosis as possible as this. Next image. So the conclusion is that hydrosalpinx should be tackled before IVF, and to improve the rates of IVF, you should do a complete, either a salpingostomy or a salpingectomy, or delink the hydrosalpinx before you take up these patients for IVF. So thank you for joining in, and we will be ready with more such videos. And thank you so much for watching. And in fact, I would just like to add that this patient had received a complete course of 9 months of ATT, and she was referred to us because her hydrosalpinx did not shrink even after ATT, when the treating doctor thought that maybe the hydrosalpinx will shrink. And now this patient will be posted for laparoscopic salpingectomy before we take her up for IVF. Thank you for joining in. See you next time. Bye bye.